Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hi, my name is Stephen Hunger. I'm a professor of pediatrics in the Perelman School of Medicine at the University of Pennsylvania and chief of the Division of Oncology and director of the Center for Childhood Cancer Research at the Children's Hospital of Philadelphia. My career has focused on clinical, translational, and basic research regarding childhood acute lymphoblastic leukemia, or ALL. One of the most exciting recent advances in cancer medicine is the development of Chimeric Antigen Receptor-redirected, or CAR T-cell therapy for relapsed and refractory pediatric B-cell ALL. Today I will present two cases that have similarities, but also important differences that highlight key questions and uncertainties regarding when and how to use CAR T-cells in pediatric ALL. Currently, the only CAR T-cell product FDA approved for treatment of children and young adults up to age 25 with relapsed refractory ALL is tisagenlecleucel, trade name Kymriah. Additional CAR T-cell products are in the late stages of testing and will likely become FDA approved soon. My discussion today will focus on tisagenlecleucel, which can persist for years following therapy. Indeed, the first child treated at CHOP for ALL with CAR T-cells in 2012 still has detectable CAR T-cells over 8 years later. Our first patient is Sue, who is currently 15 years old and has B-ALL that relapsed for the second time. She was first diagnosed at age 7, at which time she had an 80,000 white blood cell count. She was treated with standard chemotherapy with an excellent response, but relapsed during maintenance therapy 22 months following her diagnosis. Because this relapse occurred on therapy, she was considered high risk, and allogeneic transplant was considered the therapy of choice. She entered a second remission and became MRD negative after 2 cycles of consolidation therapy. Her brother was HLA identical, and she underwent a matched sibling transplant and MRD negative second remission following a cyclophosphamide plus total body radiation preparative regimen. She engrafted rapidly, had no GVHD, and was weaned off immunosuppression by 6 months post-transplant. 1 year post-transplant, she presented with bone pain and was found to have a second bone marrow relapse of B-ALL. Her leukemia cells were CD19 positive. Our second patient is 15-year-old Damien, who was diagnosed with CD19 positive B-cell ALL 4 months ago. His initial white blood cell count was 80,000, and his cytogenetic and molecular studies did not show any known high or low risk features or targetable lesions. He was treated with standard chemotherapy, but did not enter remission with 50% blasts at the end of 4 weeks of induction therapy. He received 1 month of consolidation chemotherapy with a Children's Oncology Group augmented BFM regimen, but still had 35% blasts after that therapy. He then received a 4-week course of the CD3/CD19 BiTE blinatumomab, but again had 30% blasts at the end of that therapy. The blasts remained strongly CD19 positive. His 17-year-old sister is fully HLA matched. Both of these patients have relapsed refractory ALL and meet the FDA-approved indication for tisagenlecleucel, which is patients up to 25 years of age with B-cell precursor ALL that is refractory or in second or later relapse. Sue is in her second relapse and thus qualifies. Refractory is not defined precisely in the indication, but I think all would classify Damien as having refractory ALL, given that he has failed to enter remission with 3 different regimens. The pivotal trial that led to the approval of tisagenlecleucel was called Eliana, and the results were published in the New England Journal of Medicine in 2018, with my colleague Shannon Maud being the first author. Of note, that study prohibited patients who had received prior CD19-directed therapy, so Damien would not have been eligible to enroll. However, the FDA label does not mention this, and many patients have been treated with tisagenlecleucel following earlier blinatumomab therapy. Thus, Sue and Damien are good candidates for tisagenlecleucel. Both are also medically in good condition without active infection or end organ dysfunction. There are also important differences between Sue and Damien. Sue has relapsed post-transplant, while Damien has an HLA-matched sibling but has never undergone transplant because he has never entered remission. Transplant with high-level marrow disease as he has currently, 30% blasts, is generally viewed as futile, and the best transplant outcomes occur when patients are MRD negative immediately pre-transplant. A key current question in therapy of relapsed refractory ALL is whether CAR T cells should be used as a definitive therapy, with responders receiving no subsequent anti-leukemia treatment, or as a so-called bridge to transplant, a means to get patients to an MRD negative state so that they can then undergo transplant as definitive therapy. There is no current definitive answer to this question, and these two cases help to highlight the issues to consider. Both Sue and Damien undergo T-cell apheresis with a good collection. Cells are sent to the manufacturer to make the CAR T cells, a process that takes about 4 weeks. They receive low-intensity maintenance therapy for 2 weeks, with adequate disease control, and then no therapy is given for 2 weeks. Both have adequate manufacture of CAR T cells, and then receive lymphodepleting chemotherapy with fludarabine and cyclophosphamide, followed by CAR T cell infusion. Both patients have mild signs of cytokine release syndrome, not requiring intervention. At day 30 post-infusion, both Sue and Damien are in an MRD negative complete remission and have no detectable circulating B cells. What should happen next? While some feel that the long-term efficacy of CAR T cells have not yet been established and that transplant should be used as a consolidative therapy in almost all cases, many others believe that a long-lasting CAR T cell product, such as tisagenlecleucel, can be used as definitive therapy in some cases. In the initial Eliana publication, 81% of the 75 relapsed refractory ALL patients infused with tisagenlecleucel obtained an MRD negative complete remission within 3 months, usually after 1 month. And the 12-month event-free survival and overall survival rates were 50% and 76%. More mature survival data from Eliana shows a 2-year relapse-free survival rate of 61% among those achieving remission. Like Sue and Damien, the patients in this trial were heavily pretreated with a median of 3 prior regimens, and 61% had previously undergone transplant. Knowing that many patients can survive long-term with no further therapy post-CAR T-cell infusion, there is limited enthusiasm for a second transplant among physicians, patients, or their parents if a good response is obtained and maintained. So for Sue, I would recommend close monitoring, but no additional therapy as long as she showed continued evidence of response for 6 to 12 months. I would repeat bone marrow MRD testing at 60 and 90 days and every 3 months thereafter, and measure peripheral blood B-cell numbers monthly for at least 6 months. B-cell depletion is a good surrogate for CAR T-cell activity, as normal CD19 positive cells are also killed. If Sue remains MRD negative and has no circulating CD19 positive B cells for at least 6 months, then there is a good hope that no more therapy is needed. Damien is a more complicated case, as he has never undergone transplant and has an HLA identical donor and now has excellent disease control and is in good medical condition to undergo transplant. There are short-term risks of transplant with a 100-day mortality risk of 5 to 10% for a teenager, and there are also long-term risks related to the transplant procedure and/or graft-versus-host disease. The long-term risks of tisagenlecleucel appear limited other than the persistent B-cell depletion, but the longest follow-up is only 8 years, and few patients have more than 5 years of follow-up, so we have no idea about the efficacy and potential risks 10 to 20 or more years post-infusion. Damien failed 3 induction attempts. If his leukemia comes back, one may never be able to get him back into a healthy MRD negative remission. So there is a good argument that his best chance for definitive therapy is with transplant. Given this, many would strongly recommend transplant as consolidative chemotherapy for Damien. However, it's also possible that Damien has now received curative therapy and will never relapse. Highlighting the uncertainty surrounding this question, Our group at CHOP, which has treated over 300 patients with relapsed refractory ALL with CAR T cells, does not have a clear consensus on what to do for patients like Damien. It is our practice to summarize the potential advantages and disadvantages of transplant versus no further therapy and help the patient and their family decide what is the best course for them. To summarize, tisagenlecleucel is an exciting therapy that provides new opportunities for children and young adults with relapsed and refractory ALL. However, the field of cellular immunotherapy is young, and there are many uncertainties, particularly surrounding the issue of definitive therapy versus bridge to transplant. Today, we lack the follow-up data needed to make definitive statements, and patients and families need to understand that and be full partners in these complicated decisions. Thank you very much for listening.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org.